Morgon.
God morgon Fredrik.
Pigg som fan här.
Ja, det är så kul när du ringer också på Google. Det börjar surra i alla gadgets jag har här. Telefonen börjar låta och det är inte gott att missa.
Det är lysande.
Ja. Ska vi se här om jag kan dela den.
Ja, titta. Det gick jättebra.
Fast den är lite dum för jag kan inte köra fullscreen på den.
Nej, kan inte du det? Eller kan bara jag göra det? Eller?
Alltså, jag kan inte göra det. Om jag gör det nu sätter jag den på fullscreen på min dator. Men ni ser den inte fullscreen nu, va?
Vänta lite. Jag får nästan gå in och kolla min egen YouTube-kanal också. Det här är också roligt, man får en spegelvänt. Så. Bjuda in mig själv här, ska vi se.
Ringde du Joel också, Fredrik?
Nej, det gjorde jag inte. Ska vi se, du kan nog lägga in honom i...
Ja.
Ringa honom också.
Hur gör jag det då?
Då är den här lilla längst uppe vid... Ja, nu ringer till mig själv. Ja, jag vet att det är jag själv som ringer till mig själv.
Ja, den är lite så skum. Man sitter och startar någonting så påminner telefonen om en. Ja, nu har du startat någonting. Ja, jag vet. Jag sitter ju här och gör det liksom. Det är ingen fara. Hur bjuder jag in? Men Joel, du kan inte gå med nu då? Bara.
Kan inte Joel gå med?
Han är inte med.
Jag kan bjuda in honom.
Ja, gör det.
Jag ser mig själv trippla. Jag. Ska vi se. Joel har alltså... Vad har han för snö? Joel... Heter han efternamn Joel?
Joel. Jag har han på Skype här nämligen, Fredrik. Joel.berge, eller vad har du? Joel.berge@gmail.com. Och han har ju sån apostrof på e där också. Inte i mejlet kanske, inte i mejlen förresten. Bara vanligt.
Hur ser det ut i YouTube-kanalen? Jag skulle kolla.
Jag skulle snabbt en chatt i det här också.
Det ler lite. Det ser så bistert ut.
Men nu är du med, Joel. Ja, det står det. Personer i hangouten. Fredrik Landqvist och Joel Berge. Gå in på din Google. Du kan bara öppna din mail eller någonting så borde du ha fått en pop-up. Om inte annat så har du längst ner i vänstra hörnet så har du en mittenknapp där som är sån pratbubbla hangout-ikon. Så du kan klicka på. Så borde du få upp dina konversationer.
Ja. Har jag fått inviten, Joel, eller?
Nej, han tycks inte ha fått någonting. Vilket är underligt. Och jag kan inte bjuda in honom heller för att det står att du är där. Ja, men testa gå den vägen då. Jag kan...
Nu skickar jag till... Jag skickar det till honom. Så.
Ska vi se här då. Källsida. Men här är länken till eventet. Ja, du skulle skrivit cirka klockan 8, Fredrik.
Ja, det är det. Vi ser om jag glada lyssnare. Vi kan väl börja så smått, så får vi väl ta det utifrån detta sen. De som är med här och lyssnar.
Du har ljud på 2 ställen nu, Fredrik.
Ja, det är just precis. Så. Jag behöver inte... Ja, god morgon. Lite tidigt att börja med ett frukostmöte så här dags. Men i vart fall. Jag hälsar välkomna de som kan och lyssnar. Det är så jättemånga. Men i vart fall. Vi har genomfört en uppsats här under våren. Där Alexander och Joel har intervjuat folk inom vård- och hälsosektorn för att få insikter i hur vi ska kunna använda öppna standarder för att höja möjligheterna till interoperabilitet inom vård- och hälsosystemet. Och specifikt har vi tittat på en framväxande trend som gäller att man vill titta på hela patientens resa och det förväntade resultatet av vårdinsatsen. Inte bara den specifika interaktionen, utan för det faktiskt liksom att man har gjort en fungerande liksom, operation eller vad det nu kan vara för någonting som kallas för value-based healthcare och outcome measures, som då är en teoribildning som Michael Porter har tagit fram. Flera institutioner och universitetssjukhus i Sverige håller på just nu och genomdriver förändringsarbete där man tittar på hur man ska kunna mäta sitt resultat på den medicinska behandlingen och även patientens upplevelse. Men detta tarvar ju då ganska stora förändringsbehov även då på de bärande informationssystemen som finns i dokumentationen, i olika dataflöden som både patienter och de professionella bidrar med, som vi kan hitta mätresultat som går att använda och återanvända. Och ännu mer komplicerat kan det bli när det gäller att vi ska försöka få det och lyfta det utanför kanske kliniken, utanför sjukhuset eller utanför landstinget till och med. Vi försöker hitta en gemensam norm. Så. Och i den vevan så bad jag Alexander och Joel att titta på vilka öppna standarder som finns idag och hur de skulle kunna vara ett sätt att överbrygga detta. Alla vet väl vad en standard är, men jag tror att Joel och de kommer att beskriva det här lite mer sen. Men en standard är ju då det som underlättar så att saker fungerar ihop. Man sitter i olika arbetsgrupper och diskuterar och till slut så kommer man fram till att det här är en elkontakt och den ska funka med växelström och den ska ha den här funktionen. Ungefär samma sak funkar det med datatrafik, att man kommer överens om olika lager av datatrafik som ska fungera. Exempel på detta är ju internet och det som vi sitter och håller på med just nu. Det vill säga IRC, Internet Relay Chat. En öppen standard som ingen äger. Men som gör det möjligt för oss att chatta och även då kunna ha voice over IP och röst och ljud som då möjliggör den här diskussionen. Och öppna standarder är då till skillnad från, det finns även några standarder där man får betala för att vara delaktig i standarden. Branschstandarder och andra, så är det att de ska kunna nyttjas av alla som bidrar i systemet, och man hoppas att det skapar en innovationshöjd. Men jag gör så här att jag lämnar över ordet. Jag vet inte, har Joel lyckats komma in, Alexander?
Jag hoppas att han är med, Joel.
Jag ser bara mig och dig i själva hangouten.
Så kan det kanske vara. Är du med oss, Joel? Hur går det? Du hör Fredrik, ja.
Jättekonstigt. Ja. Men Alexander, ska du börja då?
Jag börjar så länge. Ber om ursäkt för de här små tekniska problemen.
Ja.
Som Fredrik sa, så har vi gjort en studie om interoperabilitet i sjukvårdssystemen som i stora drag handlar om hur de kommunicerar eller icke kommunicerar med hjälp utav, som Fredrik sa, öppna standarder. Eftersom vi har skrivit vår studie på engelska, och ifall det är någon som inte är svensk som lyssnar på den här, så tänkte vi dra den på engelska. Så vi hoppas det är okej. So yeah, this was a study conducted in spring 2015 for the University of Gothenburg, and namely the program Software Engineering and Management. It was done with close collaboration with Findvice and our supervisor, Fredrik Landqvist. And to give you, I hope you can see my screen here, to give you an overview of what we're going to go through today. We're going to briefly discuss the background and the problem of the study before continuing to our research and its strategy, and then move on to a summary of our results and some reflections to that.
Your screen is not shared.
My screen is not shared. No, it should be shared, right? We're using this super cool tool called Google Plus Hangouts. It's almost so super cool that we have yet to master it. All right, moving on. So as Fredrik said, it is largely based around the concept of value-based healthcare, along with the evolution of big data and the Internet of Things. In healthcare today, they are striving towards a new compensation scheme called value-based healthcare. This is a concept, as Fredrik said, which was brought up by Michael Porter, which describes how hospitals should base their healthcare process around the outcome measures, or in other words, the health of the patient at the end of the patient treatment. Previous compensation system, at least in Sweden, are instead based on the compensation of single actions performed. So in other words, in order to achieve value-based healthcare, there is a need for a clear overview of the patient treatment process with measurable steps, which is, as of today, hard to achieve without interoperability. Alongside value-based healthcare, we have, as I said, the evolution of Internet of Things and the concept of big data. Internet of Things is the idea that we can have a lot of things interconnected with each other, Examples of this is, how smartphones operate, or you can connect your gadgets. And healthcare applications that are on the rise today are very numerous, and they can measure, for example, your food intake, your exercise, while at the same time you have smart wristbands that could measure your blood pressure and so forth. All this information could of course be valuable to healthcare practitioners, provided that they have the access to it. So to quickly go through previous studies in the area, they have, as we said, shown that there is a lack of interoperability in healthcare, and that these issues could be addressed by standardized communication techniques. However, standards and their implementations are today, to a large degree, based on proprietary software. In other words, they are owned and controlled by one single system supplier. This in turn has led to there being almost as many standards as there are suppliers of HISs, or healthcare information systems. So our research scope was to identify the interoperability drivers and their characteristics, as well as to see how they can be addressed by the use of open standards. Therefore, our research question 1 and 2 reads as follows. What are the interoperability drivers of HISs? And number 2, to what extent can the implementation of interoperability characteristics defined in open standards improve the flow of information in healthcare information systems? So to give you a quick overview of how interoperability works in healthcare, or how it could work, this is a picture that represents, as I said, how they would prefer to operate. Maybe not by having a single database in the middle, as this picture shows, but how several instances in healthcare could communicate to provide with better healthcare. With interoperability of this level, it would be possible to have a history within the primary care, maybe even maybe with medicine, allergies, and diagnostics, which could be used once you visit another healthcare instance. However, as we said, this is not the situation today. For instance, when receiving a referral from a primary care to a hospital, there may be a lack of information between the two, forcing the patient to act as the information carrier. An example of this would be that the patient given his information in the paper form to a doctor at the hospital. This can occur even within the same departments, which would then, of course, force the administration to having to enter the information twice. So right, we've been talking about it now for a while, so maybe we should define it. Interoperability, defined by Pukarev 2019, is the ability of multiple systems to use each other's services effectively. So what this means, at least in the healthcare domain, is that we need three parts. We need technical, we need semantic, and we need process interoperability. Technical interoperability is defined as the technical ability of two systems sending messages to each other. In other words, this means that the use of that they have to use the same protocols and communication techniques in order to be able to send the message technically. Semantic interoperability, on the other hand, is defined as the ability for two systems to interpret each other's messages. So if I, for example, in my system encode cancer as 123 and Joel encodes it as 321, and I would send him the message of 123, there would be no semantic interoperability. The third part, as I said, process interoperability, is defined as the level of which the organizations housing the two systems can use each other's messages in their particular process. Sticking to examples in our domain, this could be when one hospital deems that a critical blood sugar value is 3.0, whilst another deems it to be 4.0. This is, of course, an example taken out of the blue, but it shows you that process interoperability can be as important as the two above, more, could I say, systematic interoperability. Are you with us yet, Joel? Or Fredrik, can you hear Joel?
Yes, I can hear you loud and clear, but I can't see you well.
You can hear me?
Yeah.
Okay. I guess I'll continue then. So, an open standard then is an agreed, repeatable way of doing something. It is a published document that contains a technical specification or a precise criteria designed to be used consistently as a rule, guideline, or definition, which was taken from the British Standard Institution. What makes a standard open is that it has to be managed and defined in an open process where every interested party should be able to partake in the decision-making process to reach a consensus. It must be available free, or at least at a nominal fee. It should also be available for reuse, extend, or inclusion into any other standard under the same terms. So that is pretty much the framework and the background of our study. So now moving on to our research strategy. For this study, we chose a case study methodology, and the reason behind that is because it fit our exploratory scope. We also suspected that our problem would be affected by a number of factors, which was not clear to us in the beginning, since we had a limited knowledge of expertise in the field. Therefore, we wanted to conduct it on the level of the actors, which is why we also choose to have open-ended, semi-structured interviews. Our study included 3 major regions or municipalities in the south and southwest of Sweden. These 3 are, as you can see, Västra Götalandsregionen, Region Halland, and Region Skåne. And in total, we conducted 9 interviews face-to-face, which span from 1 to 2 hours each. The roles of the respondents was mainly IT strategists and architects, but also medical advisors and hospital logistics managers. When analyzing the data gathered, we used a thematic analysis according to a software architecture perspective. The main priority was to find the aspects related to our research questions, the different drivers that were identified, the standardizable interoperability characteristics that could play the biggest part for realizing the drivers, as well as the architectural constraints, which could be described as roadblocks to theoretical development. And yes, it is also worth noting that our research questions are based on a broad scale, but the scope of this study was Sweden, and therefore it might not be able to be generalized in other countries. So to summarize our research questions and our results, briefly, for research question number 1, we found several drivers that affected how healthcare was designed in a software architecture perspective. Numerous objectives, which mainly included the streamlining of data handling as anticipated. A lot of our interviewees also discussed possible future steps which could be realized if there were more interoperability. Most of these were seen from the perspective of the patient and included things like the ability to effectively track the patient through each step of the healthcare process, the ability to better analyze, share, and store journal data, and the ability to transparently present the workflow of practitioners. However, as we defined a driver to be both a positive and a negative force, we also found a lot of constraints to this evolution. Forces like legacy system, hierarchical politic organizations, IT governance, shadow IT, legal, and the lack of scaling agility seemed to hinder the evolution in such a way that a clear picture could not really be had. Yeah. So moving on to research question number 2, open standard characteristics. So in this question we analyzed how our drivers could be addressed with the use of open standards. And basically we found out that there were a lot of existing open standards that in theory could address these issues. In technical, for example, such as data structure, data formatting, certificates, communication protocols, etc., etc. There is a pretty common standard called HL7, or not common but prominent standard, which are used to a degree in Sweden, but not fully. For semantics, with healthcare codes and health concept structures, SNOMED CT is another standard. that could be used in theory to cover this. And Sweden is a member of its committee, so it therefore would be defined as an open standard since it's available for everyone for free.
Can you guys hear me?
Yes, we hear you.
Not sure if Frederick can hear me.
Or I hear you at least. You can't hear Joel, right, Fredrik?
I'm on mute, but I can hear you. Welcome.
Thank you. Finally, it works. Okay. I'm sorry,
Right.
I did interrupt you.
Yeah. So for the last part, process, we found that there wasn't as many prominent standards in this field of interoperability. But there is, for example, ISHOM that aligns itself with value-based healthcare to a very large degree, that defines what and how measurements could be done in a healthcare scenario. Right, do you want to take the next one, then you will, the summary?
Sure. You've been going at it for a while here.
Yeah.
So, yeah, I think this picture gives a pretty good indication of our findings. In summary, this is pretty much the picture that we got from the domain. It's not the case that there doesn't exist any open standards that cover the part of interoperability. On the other hand, there is an abundant amount of existing standards, but there is no real governance of which standards to choose. Since standards are seemingly so difficult to implement, there are instances where people try to solve this by creating yet another standard. But that just creates more standards that compete in the current situation. Yeah.
Yes, so we had read about theory in change management, which largely was applicable to this situation by Klein and Sora. So if you were to compare the situation to this theory of innovation implementation, you could see that even if you had very good innovations, such as Hålsjö, SNOMED, ISHOM, etc., the climate made up by our constraints identified in the first research questions would make up a very barren climate, as you can see on this picture. And thus an implementation would be very hard to accomplish.
Yeah, so as we saw it, in the beginning we saw technical, semantic, and process interoperability. And we started to discuss and see how we can structure it even more. And a big part here was the fact that, first of all, that process interoperability seemed to differ compared to semantic and technical in the way that semantic and technical handles the messaging and sending the messaging between systems. So we coined that term, or used a term called systemic interoperability, defining those two. But process interoperability was more of, are we striving towards the same goal here, or are we handling the messages in the right way in an organization? So this was more organizational interoperability. And then we also talked about the climate of interoperability. How can we use interoperability in such a way that all systems that handle the interoperability are striving towards the same goal in new technology? And we put those two under organizational interoperability. So it seemed for us that when we discuss this, that we have the technology, we have the process of it, but there seems to be a lack of it. Everybody have different different situations of handling new technology and discussing different ways of where should we go next.
Right.
And, yeah, all in all, it made it for a pretty bad climate, according to Kleinensor's theories. Yeah. So even though we have modern technology, it doesn't seem like there is a good way to handle that technology yet, since it's so disparate between different organizations.
And right, that is actually our summary, that probably both researchers and practitioners of this field should think about change management in a broader perspective than what it is done today. Because this interoperability climate, as we call it, but you could really call it whatever, is to a large degree what is hindering the applicability of open standards and interoperability in healthcare information systems.
I think you have managed to pull through a very good model, Alexander and Joel. And I think you pinpointed, I think the main obstacle is it's not that there is not a set of decent standards for data transfer, even standards for different, specific applications to actually interoperate. As you mentioned in your report, you have, for instance, the digital image standards in medical treatments and so forth, DICOM, and other similar ones are really existing and used to a large degree. But the problem comes back to how do one find a sustainable change over a lengthy period? Because if you have a set of heterogeneous settings of different incarnations of healthcare supporting systems, the record keeping, different, all the things that you showed in the first picture, which is basically what you can see over and over again, independently which country we're talking about, independently about region or hospital. The only difference is that they are supported by different vendors, so there's a vendor lock-in mechanism still persists. And then when we talk about technical medical IT, if you have medical IT, that's the technical facilitation of all kinds of stuff in the hospital, they are even more locked in, both due to the regulatory affairs that it has to be very secure, and they really want to sell a complete, extremely locked-in process, because that's the business model. I mean, that's the business model for the vendors to do this. So they don't see the opportunity that their set of tool set actually could provide a good data stream semantically, technically, and interorganizationally.
Right.
An opportunity.
So I think that is something that the healthcare domain must agree upon, as you said, to follow some standard, not counting in what the suppliers want, but what they want instead.
Yeah.
An interesting theory which we suggested as well could be looked at is Vick and Quinn, and as you said, do we change our systems entirely, or do we agree upon something and move towards that? And Vick and Quinn has defined two concepts called continuous change and episodic change. So where a continuous change would be slowly moving towards a unanimous goal, whilst episodic is a quick, rather immediate change where we just, okay, this is the standard we go for now, change everything. Which could be really interesting to look into as well, I think.
Yeah. I mean, there seems to be some opinions, as you said, that we should. The goal is to provide interoperability, but there seems to be different opinions about that as well. As you said, having either a common goal and striving towards it in a slow fashion, in a continuous fashion, or a deliberate change. Invest in a large amount of money to just enforce IT governance and enforce interoperability.
Yep.
You buy these systems and you say, okay, this is the new standard. This is what we follow. We've done this now. We've bought the system, and this is what we're going to use.
I think that. I mean, if you see, because I asked you to look specifically on one major overhaul and change that is undertaken with the value-based healthcare paradigm, and within that they have stated a set of, well, these are the metrics, these are the results or the outcomes that we are wanting to have a kind of a templated way of doing, regardless of whereabouts your hospital is. And then we can have kind of a balanced scorecard saying, well, obviously, if you live in a less good neighborhood in a less good city, you will probably have less good outcome results due to the fact that there's environmental dependencies in that, set of population you have, and that should even though be possible to balance, as you do with balanced scorecard.
Yep.
I think that's these kind of changes that you see with the value-based healthcare and outcome measurements is key triggers, I would say, to make do for this interoperability climate, because the only way to do benchmark is to have something to benchmark towards. Because if you just look at operational efficiency within your clinic, well, you couldn't care less about your data capture and sharing outside your clinic, because the only thing you want to know is whether how many patients did I serve up within this clinic during this period of time, and how can I make my processes within the clinic more efficient?
Yep. Yeah, I think value-based healthcare and defined outcome measures is definitely the way to go.
Yeah.
However, there is, even in that field, there is still ways to go. I think in one hospital they had defined 10 out of 200, maybe it was, processes of value-based healthcare. And there is kind of a moment 22 in there as well. If you, I mean, you can't work with outcome measures unless you have systems supporting it, and you can't have systems supporting it unless you kind of have defined it and work with it previously, right?
Yeah, but I think that I attended some of your interviews, but some of the interviewees also said that due to the fact that the practitioners, the doctors and nurses and things, are really keen on moving into this, change, and also working in a more agile and lean thinking, because these are kind of reflected in that the people on the floor, not the leadership per se, but actually the people on the floor would like to have a better work day. And by that, if the system they have, which is usually an old legacy system or a crappy health record system, that they continuously swear about how bad it is for data capturing and all the other things. I mean, I didn't hear anybody's, were happy about their existing systems, because they thought it was kind of a, what do you call it, jacket, a straight jacket.
Yeah. Yep.
It's like a straight jacket.
Yep.
By that, it means that from a national perspective, or well, even so in European perspective, what the European community within healthcare and the Swedish different government agencies and regional agencies could do is provide services or a service layer for interoperability and training and other capabilities, so that even if they have really, really bad old systems, they could at least lean upon those services online that is useful and try to tinker around and make do anyway. That's my hopeful thought around it, because we're going to wait for yet another 5 years for an integration program to buy yet another system. I mean, it's just not going to work.
No. And that's what we mean with interoperability climate, is that it seems that it's so important that everyone agrees upon one way. We have several ways to go forward from here, but it is very important that everyone agrees upon one way to move forward, so that in the end we can achieve a mutual interoperability.
Yeah, I mean, and you attended the linked data event when Phil Archer was giving his talk about what W3C is doing, trying to enforce, well, being a community council, with basically almost no employees, setting the internet standards that everybody's using on any device, anytime, anywhere, which is problematic. I mean, because as he also stated, there are conflicting interests. There are politics in this. It's power relations. It's all of these things. But in the end of the day, we have to agree on something to do something, and that's the only thing that makes W3C work, because they know that, well, for instance, as he stated in his talk, that the very used integration platform semicolon separated files, which you get from an Excel spreadsheet. The most common way, I mean, even more common than XML feeds to be used. The standardization group for that, very, very used integration point was only 5 people who had been working with that for W3C, which means, yeah, well, on a detailed, very fine granular level, on the different, kinds of medical treatments, or different kinds of diseases we are talking about. Obviously, there's going to be very different ways of capturing the data and what kind of data they want to have. But in the end of the day, if you have a cancer patient in Jönköping and one is in Stockholm and one in Göteborg, they would probably, with the same kind of outcome measures, they could at least compare how their local practices actually have been improved towards the other hospitals, and that would, let's say, give them the feedback loop to their internal systems to improve. I think we just have to finalize here, but I'm very pleased that we managed, even if it took a while for you all to join in. Now you're here.
Yeah, well, we held up.
I'm very pleased that you did this thesis. I think it's a really good read, and I hope that we are going to be able to raise some funding for this call during this call. This is what I hope for. So, and for those who have been listening or will be listening afterwards, we will provide you with the links to the presentation that Joel and Alexander have put together, and also a link to the thesis.
Yes.
And if either listener posts this in an online discussion, would like to have a more of a personal discussion. I think all the three of us are happy to join in and just share our thoughts. I don't know what you think, guys.
Yeah, definitely.
Absolutely.
Definitely.
Yeah. So I have to run for another meeting, and thank you guys for doing such a marvelous and good job. I will celebrate with you next time we meet up in the office. Okay.
Yeah.
Bye-bye.
Thank you. Bye.
Bye.